This is machine learning group 38, and our data is spatial-temporal risk stratification of latent TB using a positive-unlabeled machine learning approach using the national surveillance data. The group members are Panga Marvin, Nations Florida, me, the speaker, and then Kakoza Owen. Here are the contents of the presentations, and I'm going to briefly take you through the background. So, Uganda carries millions of latent TB cases, and these are dormant. The dormant infections act as a primary fuel source for all the active TB outbreaks. We see that Uganda has a high TB burden and corresponding widespread latent TB infection. Though there are no recent latent TB infection survey that is available, the key high-risk groups here are the people living with HIV, the household contacts, and then the health workers, minors, prisoners, and the malnourished. Brief introduction. TB remains a leading global health issue. Many people carry latent TB infection without symptoms yet. Some will eventually develop active TB, which can spread to others. Here we get to see that although the health authorities, the Ministry of Health in Uganda, has extensive TB data, for example, the survey reports we've used in our project, it is hard to pinpoint which subgroups with latent TB are at higher risk. So, machine learning can analyze the large health data sets to uncover the hidden patterns. That's what you're going to focus on in this machine learning project. Here, we see that the literature review gives us findings of the high burden in high-risk population. So, the high-risk groups face a very high TB prevalence, and the estimated prevalence rates are 16% of the population to over 50% of the population, depending on the group studied. The rising case notification rates here, it is per 100,000 population increasing significantly. We see that in 2020, 71.3 per 100,000 versus the ones in 2024, which is 158 per 100,000 people of the population of Uganda. We also get to see that the spatial clustering and hotspots here are the northern eastern districts in Uganda, like Morton, Nakapipit, and the areas bordering Lake Victoria. We also see that there are going to be the emerging clusters in the oil-rich Lake Albert regions, and these areas are quite targeted for a high TB prevalence. We see a sharp increase in active TB cases from the times of COVID in 2020 to 2024. We also see that by gender, there is much higher TB prevalence in the males compared to the females. And we go to the problem statement. A domain application problem. We see that, yes, Uganda has successfully achieved the 89% TB prevalence treatment coverage for people living with HIV treatment. Though there is a massive blind spot in Uganda whereby the government of Uganda is not sure of where to allocate the resources to prevent TB from rising into active TB. So without a recent national prevalence survey, the Ministry of Health lacks ground truth to see full extent of the latent TB reservoir, which ranges from 9.6% in children to 38% in pregnant women. Then our computational problem here, we got to find out that there were prevalence estimations. For example, there are no recent national latent TB survey that was found. There were a lot of data gaps between the dates of the national data and the latent TB infection prevalence program in Uganda. And there were such limitations, and it was hard to get references to our work. So the research questions and objectives here, we got research questions like what is the current prevalence of latent TB in Uganda? What host or behavior or environmental factors predict the progression of latent TB to active TB? Are there any geographical hotspots in latent TB infection or TB incidence in Uganda that should be prioritized first? And then, can our predictive model be developed to identify which individuals with latent TB are most likely to progress to active TB? And here are our research objectives, which include measuring the latent TB prevalence in the general population in Uganda, comparing the prevalence by subgroup, identify the host factors. We also want to identify the geographical clusters of high latent TB prevalence in Uganda. And we also want to identify the hotspots with social, economic, and environmental factors. Yeah, here are the research contributions. We managed to estimate the latent TB prevalence across Uganda and the high risk subpopulations. That is addressing the requirement number one, and identification of major risk factors driving progression from latent TB to active TB. That was the requirement number two. There was discovery of spatial or temporal patterns of TB transmission, and we were able to clean and de-identify datasets on latent TB prevalence. Research outputs include the latent TB prevalence visualizations by subgroups, the hotspot maps of TB incidence and latent TB infection prevalence. We're able to get the exploratory data analysis diagrams and visualizations. And yeah, let the next presenter take you through the research methodology.
Okay, hello everyone. I'm going to begin with methodology and architecture. Our pipeline has three layers. Layer one, data collection and integration. We integrated four nationally representative datasets: the Uganda National Prevalence Survey of 2014 and 2015, the DHIS2 records from the 2020 to 2025, the NTLP annual report 2023 to 2024, and the WHO Uganda country pipeline 2024. And then in layer two, pre-processing and future engineering, we clean the data handled missing values using mice, multiple imputation by chained equations, and aligned all records to the unified district year index. We applied spatial feature engineering using G hotspot analysis and DB scan, clustering, and kernel density estimation to protect the geographic concentration of the risk. We also enforced a strict temporal forward split training of data from 2014 to 2023, testing only one unseen 2024-2025 dataset. This prevents spatial-temporal data leakage, which is critical to methodology, which is a critical part in methodological. It's a critical methodological requirement. Sorry. Then on layer three, we have here we did modeling. We applied 12 complementary analytical methods, including GMM, K-means, UMAP, FP growth, and PUEM, XGBoost, NFM, and Bayesian networks and structural equation models. The primary model is PUEM, positive-unlabeled expectation maximum, which is specifically designed for the scenario where they only have labeled positives and a large pool of unlabeled records that may contain hidden positives. The pipeline output flows directly into the Ministry of Health allocation dashboard. To the dataset description and exploratory data analysis, we integrated four datasets: the Uganda National TB Prevalence Survey, which approximately has 55,000 individuals across 30 districts with confirmed LTBI and active TB status. This is our labeled ground truth, the seed for positive-unlabeled EM algorithm. Dataset 2 was DHIS2 for 2020-2025. It had 135 districts and it had 72 months of facility level records, including TB notifications, drug consumptions, and ad coverage. And this is our primary unlabeled corpus, and it is large and spatially comprehensive, but it has no explicit LTBI labels. And then dataset 3 is NTLP annual report for 2023, and then dataset 4 is the one for WHO Uganda country profile of 2024. Before any modeling concluded, any modeling was conducted, we conducted rigorous harmonizations of temporal alignment to a unified year math index, spatial standardization of district identifiers, spatial imputations of missing values, and data validation to confirm no duplicate records. Our EDA revealed that only 23.9% of surveyed individuals with TB symptoms sought formal health care, meaning 76% of the cases never reached the health system. This notification prevalence gap is the strongest empirical justifications of deploying the PU learning. Okay, and as you can see, these are our results from our training when we trained the models. The correlation heat map reveals strong positive correlations between HIV prevalence and TB notification rates, validating that HIV status as the dominant risk of it's a dominant risk predictor. And it also shows that malnutrition index correlates with both HIV prevalence and poverty index, suggesting that the factors cluster geographically and cannot be treated as independent. For the Chemin's cluster map, based on the 10 future district matrix, it identified 4 epidemiologically interpretable population segments. As you can see, cluster 0 is low risk, rural youth, primarily in southern and eastern Uganda. Cluster 1, moderate risk, peri-urban workers, greater Kampala belt. Cluster 2, high risk HIV positive adults, urban corridors. Then cluster 3, very high risk, minimizing the West Nile and the priority intervention zones.
Yes, good evening, members. Welcome to the YouTube channel. My name is Kakoza Maipowen, and I would like to take you through the slides to the end in the conclusions of why we chose the positive-unlabeled EM model for the estimation maximization model. So to continue, this is the graph talking about resource optimization, looking at the targeted versus the uniform allocation. When we talk about uniform allocation, we mean that funds are going to be distributed equally throughout the entire districts. But that is not the best, because as we talked of this model earlier, that here we are looking at people who are already sick, whom we are identifying, and due to many factors, we find out that even they are unevenly distributed. There are districts with more, there are districts with less. So the fundings, you can see them, but to go here to talk about them briefly, you see that when we implement the PUM model, we save up to 256 billion Ugandan shillings. Reason being that here we are significantly focusing more allocations on places where we have got to know that here there are numbers of people who are sick, and based on those numbers of people are the resources we are to give. Unlike other models that we talked of, like the SCM, which looks at only facilities. So when you try to focus on the SCM model, when we talk about facilities, we find that for it we shall cost more, because not all facilities should be treated equally. And remember, this is about tuberculosis. So let us continue to the next slide. These are the scores against other models. Still, it goes back to the same point. So here you see in the combating latent tuberculosis, this one gives higher because here we have identified people who are sick. That is one thing, and the disease is treatable. Resource allocation, which I've just talked about. Your machine learning implementation. So that means here we are to implement based on the people who we already know that they are the ones who are sick, unless like just predicting or speculating based on other models. So this is also another graph which it was similar to the other one before. So to continue more to the conclusions, these are the recommendations to the Ministry of Health that we suggested. One, we trained our model on 30 districts due to our data sets. And we found out that based on that, to broaden it further to the entire country, the percentage was about 31.2% on the 30 districts to the entire country. That is about 14 million people. So that one gives about 400,000 active tuberculosis cases per year. So this is the recommendation. Remember, our recommendation is about building a dashboard system. And when you talk about the dashboard system, here we are talking about a system whereby you are going to diagnose facilities, the hospitals, research centers, based on the ESM system, ESM model. The BN or the Bayesian model is going to give us in the risk factors that cause to the disease, factors affecting age, factors whereby you talk to this disease common in people among HIV. And then the PEM model, it will be for prevalence. This is for identification. So we shall expand up to 135 districts to cover all. Replace the entire ESME data with the district health information systems 2 data set. And by then, we shall have optimized savings of up to 143 billion Ugandan shillings. So the acknowledgements, these are the people who helped us in carrying out this project. Dr. Galiwango Marvin, our lecturer. Alison.com, where we got from our diploma program. Our lecturer also, Dr. Efrans Yunis, who helped us also in the insights throughout the entire research, insights concerning machine learning and guidance on how to train these models. And lastly, this is the college where we went to at Makerere University. With that, I'm very grateful for your time and wish you the best.